Good morning, everybody. Happy Saturday. Well, today I want to welcome you to the third and final day of the Community Liver Alliance's National Liver Gathering. I can't believe it. I'm so excited and energized. Over these last few days, we've really had a chance to explore the alcohol-associated liver disease along with autoimmune liver disease, MASH, metabolic, liver health with viral hepatitis elimination and harm reduction. We've heard from patients and caregivers, clinicians, researchers, and advocates, but most importantly, we've built a connection across the whole liver community. And that bridges our science, our lived experience, and our policy. So today, we turn our focus to transplantation and liver cancer, and pediatric liver diseases in the afternoon. These are among the most important components, and they're complex and urgent areas of liver care where innovation and collaboration can truly transform outcomes, from improving pathways to transplantation to advancing multidisciplinary care for hepatocellular carcinoma and bile duct cancers to addressing the unique needs of children and families. The final day brings us together amazing experts and perspectives that will challenge and inspire us all. As we begin, I encourage you to carry forward the spirit of this gathering, listening deeply, sharing openly, and looking for opportunities to act together. The work we do today will not only shape the future of liver care, but also reaffirm our commitment to patients and families that depend upon us. It is my pleasure to introduce our opening plenary speaker, Dr. Christopher Hughes. Dr. Hughes is a leader in transplantation and cancer care whose work bridges cutting-edge research, multidisciplinary clinical practice, and patient-centered approaches. His expertise focuses on driving innovation from the laboratory to the bedside and ensuring patients benefit directly from scientific discovery. Dr. Hughes' leadership has advanced models of care that integrate patient empowerment, improving both outcomes and the lived experience of those navigating transplantation and cancer treatment. Please join me in welcoming our pal, Dr. Hughes.
Well, thank you, Susanna, and thank you to the Community Liver Alliance for the opportunity to speak today. Susanna picked out this title for me because I'm usually too wrapped up in my own world to think about patient empowerment. It's not a word I typically use, but it's real fitting for this, as it turns out. So she came up with a better title than I could have come up with. There's a new field of medicine that has developed over the last 5 to 7 years or so, and that's the field of transplant oncology, using transplants to treat cancer patients, and particularly in the field of liver transplantation. And it's come up because we've had more survival of patients because of the advances that have been made in like chemotherapy and local regional therapies that we'll talk about. And so patients are living longer, and they're living with liver cancer even spread from other organs that's now just isolated to the liver. And so those patients now can potentially become transplant candidates. And also because we've made advances in making livers available for patients through techniques to get more deceased donor livers and advances in living donor liver transplantation. And so when we talk about patient empowerment, basically, we're talking about options for patients. Patients are empowered when they have options for treatment. If they run out of options, then they're not empowered at all. And so it's pretty neat when you see, I'm going to kind of do a wide coverage of the field of liver cancer and just think about all these potential therapies we can use to treat patients now. The field of transplant oncology in terms of the liver basically is encircled around 5 types of cancer: hepatocellular carcinoma, intrahepatic and hilar cholangiocarcinoma, neuroendocrine tumors, and just so you know what those are, I put it down here. Neuroendocrine cells are specialized cells that sort of communicate between nerve cells and hormonal cells, and they're scattered throughout the body. They're in the lungs, they're scattered throughout the abdomen, and those can give rise to tumors that eventually can go to the liver. And colorectal cancer, which has spread to the liver. Very common in the United States, of course. But curing these cancers means we have to get them out. There's no real cure without taking these out. And some of them we can take out with resection, like removal, but a lot of them we can't, mainly because of underlying liver disease. For example, hepatocellular carcinoma almost never occurs in somebody who doesn't have cirrhosis. And you can't just cut out the half of the liver with the cancer in it, because the other half is not healthy enough for the patient to survive with. So then you have to think about taking the whole liver out, which is transplant. So what is a cancer? So a cancer is a single cell that's basically started to grow out of control. And the type of cell that cancer comes from is what determines the type of cancer that it is. That makes sense. So when we're talking about cancers of the liver, we have to think of it from two perspectives. One is cancers that start from a cell that is in the liver, and the other type is cells that develop a cancer somewhere else that have spread to the liver. So we have cancers that start in the liver and the ones that spread to the liver. For the ones that are inside the liver, what kind of cells are in there that could form a cancer? Well, in the liver, it's basically blood vessels, a lot of blood vessels, artery and veins. And then there's what I call the blob part of the liver, which is the hepatocytes. Those are all the main functional liver cells that are packed around the blood vessels. And then the bile ducts. Blood vessel cancers are rare. We almost never see those. So we can take those out of our discussion today, which leaves us with just the blob and the bile ducts, right? The blob is the hepatocytes, and the hepatocytes are packed. The hepatocytes are packed tightly around the blood vessels. So this is an electron microscopic view of the liver with the blood vessels removed. And the hepatocytes are these cells that are packed tightly around where the blood vessels were. You can see how this kind of forms a net, like a trap or a sponge, that could, if a tumor cell was trying to go through here from somewhere else, why it would get stuck in there. That's why so many tumors go to the liver and get stuck. So if a cancer develops from one of these cells, it's a hepatocyte cell, so it's a hepatocellular carcinoma. The other type of cell are the bile duct cells, and the bile ducts are lined by these cuboidal cells called cholangiocytes. Cholangio means bile duct, cell is site. So if a tumor comes, or if one of these starts to grow out of control to become a cancer, it's a cholangiocarcinoma. Makes sense. Now, there's a difference between the bile ducts in the liver and the bile ducts outside the liver. Remember, when I talk with patients, I explain to them that the bile ducts are those tubes that carry the bile from the liver. And just for ease of discussion, the bile is all the stuff that the liver wants to get out of the body, that it's cleaned out of the bloodstream. It sends that bile through the bile duct tubes where it empties into the intestine. And so the bile duct actually has to go through the pancreas and then it goes into the intestine. So part of the bile duct is in the liver, part of it's outside the liver. The part that's way outside the liver, like in the pancreas and stuff, we're not worried about that. That's not a tumor of the liver. That's a tumor that involves the pancreas. So liver transplant is not going to help those kind of tumors. But right at the crux of the bile duct, where the bile ducts join together from the right and left sides coming out of the liver, is a place where particularly these cells like to form cancers. And there was this guy back the year I was born, 1965, he wrote a paper is named Gerald Klatskin. So these are Klatskin tumors. Gerald Klatskin was a professor at Yale, and he said, hey, a lot of these cholangiocarcinomas, they're forming in the bile ducts right at the crux of the bile ducts where they come together right outside the liver. And the theory behind that is that in fetal development, the bile ducts that are in the liver develop in a different place than the bile ducts outside the liver. And then in the fetus, about the 12th week, those two systems join together. And the joining point, they think, is where there might be, for some reason, more genetic aberrations that could take place that lead to cancers forming in that area of the bile ducts. But we consider, the transplant surgeons, we kind of consider that as a tumor of the liver, even though it's just right outside the liver. What about the cancers that come from outside the liver? Well, historically, we haven't really considered these cancers to be cancers that we would transplant somebody for, because we want to transplant somebody to cure them. So if there's tumor outside the liver, we're not really curing them with a transplant. But with advances that have come along in chemotherapy and immunotherapies and local regional therapies, we can now start to consider some of those cancers that spread to the liver, as long as we get rid of the primary tumor as well. So, what tumors are the ones that spread to the liver? Well, they're the ones that have their blood flow that goes straight to the liver. So all of these organs have their blood go through the portal vein and through the liver before it goes back to the heart. So this is called the portal system. This is how all the blood drains from those organs. So if there's a cell, for instance, in the colon, cancer in the colon, and it breaks off a cell to spread somewhere, where's it going to spread to? Well, it's going to spread and it's going to get caught in that trap of the liver, and it's going to grow in the liver. You might say, well, what about kidney cancer? Kidneys don't drain in the portal system. They go behind the liver to the vena cava to the heart. So kidney cancer doesn't usually spread to the liver. Same thing for like uterine cancer, different, it's going to spread other places, not to the liver. And you could say, well, what about these other organs, spleen? Well, spleen doesn't usually form malignancies. What about the pancreas? Pancreas cancer is really locally aggressive, really aggressive. And so by the time that we get to a pancreas cancer and get it removed, it's usually grown into lymph nodes and other areas. So it usually doesn't just go to the liver. But colon cancer does, and there's going to be 150,000 cases of colon cancer this year. And neuroendocrine tumors, remember those specialized cells I told you about? They're scattered throughout the mesentery. Some are in the pancreas. So sometimes they can form a cancer, and that goes to the liver. This is the other kind of cancer starting from outside the liver that we can potentially transplant somebody for. But we have to remove the primary tumor. So if we have a patient who comes to us and they've been diagnosed with colon cancer in the sigmoid colon that's already spread to the liver, we could potentially transplant them if we remove the primary first. And we do the best that we can to make sure that there's no tumor anywhere else. So if we're going to make somebody transplantable, if they have colorectal cancer or neuroendocrine tumor cancer, like a colorectal cancer in the sigmoid or a neuroendocrine in the jejunum, if we remove these first, now we've turned them into a person with just liver cancer, and we can potentially transplant them. For the other types, the ones that come from inside the liver, hepatocellular, intrahepatic cholangio, hilar cholangio, most of these patients have underlying liver disease. Like the cholangiocarcinoma patients, most of them have primary sclerosing cholangitis. Most of the hepatocellular carcinoma patients have whatever, fatty liver disease, whatever that causes cirrhosis can lead to somebody with HCC. So these, we don't have to do anything else. We just have to make sure we don't have to do any other surgeries or removing any primaries because the primary is in the liver, so that patient may be transplantable. But we got to make sure when we transplant them that we didn't leave any tumor cells anywhere else. Okay? And the reason is, when we're healthy and we don't have any liver cancer, there are cells in our body which are basically kind of doing cancer surveillance. So that if a cancer cell starts to develop, a cell starts growing out of control, that these cells will take care of it and kill it before it turns into cancer. We're probably doing that all the time, forming one of these cells, and it gets taken care of by our natural immunity. Natural killer cells, macrophages, dendritic cells, T cells, neutrophils, all of these work to attack cancer cells in our own bodies. But if we're going to have a patient who has liver cancer and we're going to transplant them, if we have tumor somewhere else, like let's say there was a spot in the lung that we didn't catch, or that was too small at the time to show up on our imaging, and now we transplant their liver and give them a new liver, leaving this behind, but now we have to put them on immunosuppression so that the liver is tolerated and not rejected. And what does the immunosuppression knock down? All of the natural immunity that we have for cancer surveillance. So now we've taken a person who just got a liver transplant to fix this big problem that they had, but now this is going to grow much faster than it otherwise would have. So we potentially may have done this patient a disservice by putting them through this whole process. So like I said, transplant is for cure, but should we just rush off to transplant? We need to get them, hey, I've been diagnosed with cancer, we got to get it out right now, right? Well, that's what you would think, but that's not the case. Actually, it's just the opposite. For some of these aggressive tumors, particularly the ones that are outside the liver, that go to the liver, we need to buy some time. Time to sort of select which patients are going to do well with the transplant. Okay? Well, for one thing, we need time to get a liver too, because we don't have, just livers hanging out. So we either have to evaluate a living donor and put them through the process of evaluation, or get a person on the list and wait for a liver to come available, which could be, months, who knows. But basically, while we're buying time, we need to contain the tumor in the liver so it doesn't go anywhere else. And we need to treat that tumor and give us time to see, is anything else going to pop up in the body in the meantime? That was just too small when we first saw this patient. And how much time do we wait? Well, it depends on what kind of cancer it is, because the cancers have different levels of aggressiveness and different propensities to spread. So for hepatocellular carcinoma, we don't wait at all, because it's compared to these others, it's pretty indolent. It doesn't really go other places until it's pretty far advanced. So we can go ahead and get this patient transplanted. Hilar cholangiocarcinoma, we do chemotherapy, radiation therapy for 6 weeks, and then we say, okay, we've done our scans, we don't see anything else, we've put you through 6 weeks of waiting, we can go ahead and get you listed for transplant. Neuroendocrine tumor, we really don't wait for that one much either, and the reason is neuroendocrine tumors now are so well treated with chemotherapies and actually particularly immunotherapies, that even if there was tumor left behind, that person can live for many years, even if they had some neuroendocrine tumor left behind. So we don't really wait on those. But for the intrahepatic cholangiocarcinoma, very aggressive, and for colorectal mets, having come from somewhere else, we want to wait 6 months. And it's hard to tell a patient, hey, we're going to wait 6 months when they know they've got cancer in their bodies. But that's what we've got to do to make as sure as we can that we don't have tumor outside the liver. So we don't call that delaying. Doctors call it bridging. We're bridging you to transplant. Now, one of the things that we can do, starting to look at treatments now for cancers, next generation sequencing is what we can do to look at tumor tissue and determine what genes are abnormal. You know, cells start growing out of control because they've lost their genetic control that is inherent to those cells. It's become abnormal. There's been some genetic aberration. And the type of cancer that it is has different types of genes that have become abnormal. And those genes give rise to products that can be attacked with immunotherapies, antibody therapy. So when we have one of these aggressive cancers, we'll do this sequencing. We'll look for some of the abnormal genes and see if there's anything targetable with antibody therapies to treat this patient with, and we would put them on one of those antibody therapies. And of course, we have chemotherapies that have been studied for a long time, and more trials are going on with chemotherapies. And chemotherapies, basically, chemotherapy drugs just attack cells that are rapidly dividing, essentially. So that's how they discern cancer cells from other cells in the body. We're just going to attack the ones that are rapidly dividing. That's why people lose their hair, because the hair cells are rapidly dividing. Those are standard chemotherapies. But we can combine the chemotherapies and the immunotherapies and keep a patient on those during that 6 months. And are we trying to really treat their cancer? No. We're just trying to make sure that if there's any one or two or whatever cells that got out during that time, these chemotherapies would take care of it. But if there's a larger area that we think is going to grow, these probably aren't going to hold it back, and it's going to show up on a scan, and we're going to say, there's a place in the lungs, we can't transplant this patient. Does that make sense? In the meantime, why not try to kill what's in the liver? Why not try to kill those tumors? And when you talk about options and patient empowerment, look at all these things, and I'm going to show you that we can do to try to kill the tumor that's in the liver. And then we've got some limits to this, because all of these things don't just kill the tumor, they kill an area of liver around the tumor. And so we can start to get, and we had one patient come to us who had metastatic colorectal disease, who was in liver failure because of so many treatments with this local regional therapy. But one thing we can do to try to kill the tumor that's in the liver while we wait for transplant is transarterial chemoembolization. We run a wire in the artery from the groin up to the tumor, right out to the tumor, and we inject high-dose chemotherapy right on the tumor. And then we squirt gel foam in that artery to block off the blood and oxygen supply, which suffocates that whole wedged area of the liver. That was called TACE. This is called TARE, transarterial radioembolization. We do the same thing, run the wire up, but instead of injecting chemotherapy, we inject radiation beads. This is yttrium-90. And if you're nerdy like me, you wanted to know where it was on the periodic table, there it is, there's yttrium. But you think about what goes into these treatments. You know, a person comes in, oh, I'm getting my Y90 today. Yttrium is an element, it's a rare earth element. It's yttrium-89, actually. Yttrium-90 doesn't exist naturally in the world. It exists from radiation decay of another radioisotope called strontium-90. Strontium-90 starts to decay, and it gives off yttrium-90. Strontium-90 was in Chernobyl. That tells you how bad that is, okay? Strontium-90 has a half-life of 30 years, and it sends beta emission, beta radiation from one little particle or one little atom of strontium-90 will go like meters, like 10 meters. So when you got all that dust from the explosion of Chernobyl, that's why there was so much bad radiation everywhere. So then you're thinking, why would you put this in the body? Well, they're actually able to harvest, so think about what it takes to get this for this procedure. They actually separate the yttrium-90, which is decayed off the strontium-90, and put it in resin beads to inject. And it only has radiation which goes about 0.5 centimeter. So when you put it into the tumor, inject it into the tumor, each of these beads is giving radiation to that little area around it. And so that's how it can kill the tumor. And it's half gone in about 2.5 days. So each 2.5 days, it's divided in half. So pretty soon, it's all gone as far as its radiation activity. Pretty neat thing. Wouldn't have been the guy that thought of this. So he must have sat in his lab late at night going, what can I do? Stereotactic body radiation therapy is making a resurgence. Actually, we're using it more and more. Everybody's heard of external beam radiation. This actually uses multiple convergent beams. It can be really focused. And so that's another way of doing radiation therapy, which is highly accurate. And it's non-invasive. Liver histotripsy is, there's a resurgence of that now as well. That's ultrasound. Basically, very high energy ultrasound is used. And the way that works is the ultrasound waves cause bubbles of gas to form in its target, which is the tumor. You focus it on the target. Bubbles of gas form in that, and they explode. And it basically uses shear forces to disrupt the tumor. Some of these are kind of cool, you have to admit. Radio frequency ablation we use multiple times a day in our hospital. It uses high frequency alternating current to create shear forces in the tumor. It can be done percutaneously. They put a long needle into the tumor, or it can be done in the operating room under ultrasound guidance to show where the needle's going. And when the needle gets in the tumor, they push out these tines like a pitchfork. And these then generate the electrical current, and that causes the tumor to heat to 2 or 3 times normal body temperature, upwards to 100 degrees Celsius. And that kills that area of the liver with heat. It's good to about 3 centimeters or so not a big area. Microwave ablation, very much similar to radio frequency ablation, except it uses a much higher frequency. It uses a microwave frequency instead of a radio wave frequency. And that means it heats up tumors faster and can maybe a little bit more, at least time efficient. If you have multiple procedures to do, this is a faster one. And then lastly is the hepatic artery infusion pump. And that's used in patients, particularly people who are undergoing resection of a colon cancer, but they have cancer in the liver. They'll implant a pump in the abdominal wall that has a catheter that goes into the artery to the liver, and that can have chemotherapy injected into that port to give chemotherapy directly to the liver. So all of these, so when you talk about options and empowerment, there's a lot of options that we have for treating liver tumors. So who makes a decision about what patient gets what combination of all of these types of treatments? Well, it's by a whole team of people. The transplant surgeon being the least of those, really, we're kind of like the orangutans of the group. We're just kind of, me put liver in. Every Wednesday, don't call us on Wednesday afternoons because we present about 10 or 12 patients. We have the radiologist showing the films, we have the pathologist showing the slides, and we have all of these people making decisions about this person needs this chemotherapy, they need this immunotherapy, and they need to have local regional therapy with this. We're going to schedule it for this day, and then we can start to make assessment as to whether they're going to be a transplant candidate, when they should come in for their evaluation, all of that. So all that happens at a tumor board meeting. There's probably 30 or 40 people on this at this meeting every week. So when we talk about transplant, I told you we have to get a liver first. So bad news first, the wait list is long, and it's not getting really any shorter. We thought when hepatitis C treatments came along that there would be a dramatic decline in the wait list, but it's been replaced by fatty liver disease. And so we're seeing continual increases in the number of patients being waitlisted. And there are new indications for transplant now, like these cancers that I'm mentioning. So these are more people that are not fighting, but waiting for an unavailable, sometimes, resource. The good news, though, is that we're doing more transplants. Through advances that we've used to use more deceased donor livers, and also with living donor liver transplantation, which is particularly helpful for these cancer patients. One way that we've increased the number of deceased donor liver transplants is with machine perfusion. And so we can take a liver that previously we may have said, you know what, we're not going to use that liver, it's not a very good liver. But remember, these livers are in patients that have been declared brain dead, for instance, and their other organs are starting to fail. Maybe this liver would work better if it was outside the body and we could assess it that way. So this liver is actually functioning. It has blood and oxygen flowing to it. It's making bile that's being collected down here. We have vital signs on the liver, and we can do labs on the liver, and we can see, it's oxygenating great. It's actually clearing lactic acid. That's one of the main functions of the hepatocytes. So we can say, you know what, this liver is a pretty good liver, we're going to use it. And so by this, I think soon probably, we were just talking earlier, probably half the livers transplanted from deceased donors in this country pretty soon are going to be put on one of these devices. Living donor liver transplant is the other option. Not all centers do it. There aren't many centers who do a lot of them. We do the most in the country. And the benefit of having a living donor is because you have your own donor. We can schedule when we want to do your operation. And so if you have colorectal cancer mets, we can evaluate your donor so that when you finish your 6 months of wait and your chemotherapy and your local regional therapy and all that, and we determine, yes, we're going to go ahead with the transplant, we can do it today. We don't have to wait the months or however long it might be for a liver to come from a deceased donor. Because then you're saying, okay, do we keep treating them with chemotherapy? Should we do more local regional therapy? What if we start their chemotherapy today and a liver comes tonight and we just had this patient on chemotherapy? So it's not good if you can't really control the time. And I think that's been our biggest benefit in treating these patients, is because we have living donor transplant program. So I'm just going to give you a couple cases and I'll wrap it up. This is a patient that came to us with intrahepatic cholangiocarcinoma. She's 65. She had NASH cirrhosis, so her liver, fatty liver disease. Her liver's not healthy, so we can't just go in and remove the half of the liver with the tumor in it. She's going to need to have a transplant. She presented it to us in May, and we talked about her at our tumor board in May of 2019. We started her on the chemotherapy, and we did that TACE procedure. We chemoembolized this tumor to her liver. And then we waited the 6 months. We did our scans right before the transplant, and we didn't see any disease. And then when we took her to transplant, and we do this for all these advanced cancer patients, before we take her donor to the operating room, because these operations, her donor and her operation are going to happen at the same time with operating rooms right next to each other. But before we take her donor to the operating room, we're going to look inside her first. Look in her abdomen, check some nodes, let the pathologist see if there's any tumor inside the lymph nodes. And then if all that's negative, that takes a few hours. Then we'll take the donor to the operating room and we'll proceed with taking her whole liver out. So we did that on this lady. Here was her tumor beforehand, 5 centimeter cholangiocarcinoma in segment 5-6. That just means it's on the right side. This is her liver when we took it out. That's what fatty liver disease looks like when it gets cirrhotic. It's not that nice maroon, smooth color. It gets all yellowy and bumpy like that. But here's her tumor, 5 centimeter tumor. And look here, here's some areas of tumor that were outside that tumor. So let's say you had resected this, this would have recurred. Okay? Here's the half of a liver that we gave her. We gave her the right lobe of her family member's liver. It wasn't this big when we put it in, that right lobe grows, it regenerates to be the size of the liver that she needs. So we gave her about 60% of a liver, and it was almost 100% within about 8 weeks. And the same thing happens in her donor. And they don't grow new lobes. Like she got the right side, she just gets a bigger right side. And her donor grows a bigger left side. For those intrahepatic cholangiocarcinomas, we've done 8 transplants. With between 18 months and 6 years follow-up, we've had 1 recurrence. That person recurred quickly. It's something that didn't show up on any of the scans, came up in the lungs, progressed rapidly like we talked about why it can happen, and he died. But the others, this diagnosis is a death sentence without these treatments. So when you're talking about really, really low chance of survival, it's pretty remarkable what can be done today. And then the last case is a guy who had colorectal metastasis to the liver. He was 66. He actually was having pain in his abdomen, and they did a scan and saw these places in his liver. And they biopsied it, and they said, this looks like colon cancer. And then we looked at his colon, and he had a 3-centimeter rectal cancer, which was removed back in 2016. And they started chemotherapy. That's what Folfox is. They started chemotherapy. In 2017, they did Y90 to his whole liver because he had so many tumors. And then he was sent to us, but he'd already had his 6 months of time. He didn't have any spread anywhere else. And so after a 2-year wait, 2.5-year wait, we presented him to our tumor board for a plan of what to do. We said we should transplant him now. And so this was his scan before surgery. Look at all these areas of tumor. These look mostly dead, probably from the Y90. But this is the guy that had had pretty bad liver failure from so much treatment. You'll see why when I show you his liver in just a second. Look at this. This is his liver. So look, here's a tumor. Look at this area. This is radiation necrosis outside the tumor. So this is where those Y90 beads went. But you can tell this liver is not really going to function to do much of anything. We've got to get that out. So we transplanted him. I think he got his son's liver. He got the right lobe. We usually transplant right lobes into adults. And he's now 5 years out with no evidence of recurrence. The results with colorectal cancer have not been as good, and there's 2 parts of that. One is the overall survival is pretty good. It's about 80% over 5 years, but the recurrence rate is high. It's about 50%, meaning we're not doing as well trying to catch those cells outside the liver. But we've restarted the clock. These people can now be treated for the cancer that they now have, which is different than what they had before in the sense that it's in a different place. And even if it recurs, even if tumor makes it back to the liver, they can be treated again with local regional therapy or chemotherapy, and they may get years of life, even though they had recurrence. So conclusions, basically, we empower patients by giving them options to treat them. There's lots of options. For cancer involving the liver, the timing of how we consider transplant is key, and living donor liver transplant allows us to do that optimum timing. Thank you.